Hello, I'm Dr. Benjamin Strong, the Chief Medical Officer of Virtual Radiologic, or vRad. I started my career with an internal medicine residency and followed that with 3 years of work as an emergency physician. I then returned to training for a radiology residency and a fellowship in body and MSK MRI. In the course of my over 20 years in radiology, I have worked as a private practice radiologist, an academic radiologist, and for the last 17 years as a teleradiologist for vRad. I have been the chief medical officer there for 8 years and am licensed to practice in all 50 states. Emergency neuroradiology, and I've broken these into a collection of emergency cases and a collection of trauma cases. So we'll be looking at 48 neuro cases. These are all non-contrast head CTs. Few straightforward ones, a dermoid rupture. When you see fat density intracranially, you know the problem, certainly. Suprasellar cistern there, you can see that fat density, and once these rupture, they spread all throughout all the sulci and coat all the surface of the brain. It often helps to window these and make sure that that is in fact fat you're looking at. So here is the windowed version. And just to let you appreciate the extent, that dominant focus of fat is almost certainly the original lesion. You can see how widespread this is. So this apparently causes quite an acute chemical meningitis, and these patients are not at all comfortable. That is an acute dermoid rupture. This is a neat one. Again, those inferior horns can be so helpful. They're a great gauge for early hydrocephalus, especially in the younger folks. When you see them this prominently, you know there's hydrocephalus, and sometimes they can look like this without the lateral ventricles necessarily being enlarged. There is apparently less resistance in the white matter of the temporal lobes to expansion of the ventricles. So in this case, though, there's hydrocephalus elsewhere as well. Some enlargement of the lateral ventricles, and then you can see this rounded density, a colloid cyst, pretty much classic appearance. This is what's known as Brunn syndrome, when people actually present with a symptomatic colloid cyst and hydrocephalus. Typically that presents as a recumbent headache. So unfortunate, these colloid cysts, they're just practically a dime a dozen and you rarely see them cause a problem. But when they go south, they can be an issue. There is a colloid cyst with hydrocephalus. All right, this is a basilar artery aneurysm with hydrocephalus. This particular location can result in significant hydrocephalus, and it in fact can be how these folks present. So here is the hydrocephalus, and there with that peripheral curvilinear calcification really just screaming to you that this is an aneurysm, pressing back against the brainstem and aqueduct, and ultimately blocking passage of CSF. And you saw the normal size fourth ventricle go past right there. And there are the dilated lateral ventricles. So you see it again there, the fourth ventricle, and the pressure of that aneurysm against the brainstem, resulting then in non-communicating hydrocephalus. You can see at the top part of the aneurysm, there's another stretch of vessel taking off to the PCA there. So that is a basilar artery aneurysm presenting with hydrocephalus. This one's pretty striking. So there's a rounded density here at the carotid apex that looks for all the world like acute hemorrhage, and probably some sulcal density there as well. There's also multiple locations of cortical hypodensity. You can see it in the medial right temporal lobe as well, frontal lobes, and really throughout the brain. See patchy involvement, all these hypodensities seen all throughout. There is intraventricular density layering back here in the occipital horns. That is especially frequently missed in elderly patients, so make it part of your search pattern. I look there every single time, and I think so should every radiologist. Note again, all these cortical hypodensities, the unusual appearance, they do go to the periphery and they look for all the world like small infarcts, all sporadically distributed throughout the brain. And that's what this was. This is widespread vasospasm. There was a carotid apex aneurysm that blew, and it caused widespread vasospasm with multiple infarcts scattered throughout the entire brain. The truly amazing thing about this case, look at that involvement all the way up to the top. I'll let that run one more time since it's so impressive. So this is all related to vasospasm, and the amazing thing about this case was that it was all reversible. This patient walked out of the hospital no more than a week later, and on the follow-up scan just about 3 days later, it was so normal that I didn't bother saving it, which is pretty impressive. So incredible to believe that that could have resolved and this patient really survived very well, but that was in fact the case. All right, this one's pretty impressive. A couple of patterns that you really need to spot. A rounded calcification, which always suggests a venous lesion, right? Something vascular, probably venous. In addition, there are all these tubular densities, and there is that intraventricular density, right, within the third ventricle. But look at all those tubular densities as well. You know for sure, just looking at this one slice, that you are dealing with a vascular lesion. So let's take a look at this. This, of course, is a giant AVM. There was that cortical calcification. There is the large draining vein. Watch that one posteriorly. You can see a huge draining, probably basal vein of Rosenthal. That was showing us the intraventricular hemorrhage. We'll start over here. There's the tubular lesion, calcification. There's the basal vein of Rosenthal, which is draining it all. And then the intraventricular hemorrhage. I've had a few of the newer radiologists sometimes ask, why is the clot smaller than the ventricles? You can see this is a great example of that, right? The clot is smaller than the fourth ventricle, than the third ventricle, and the lateral ventricles. And the reason, of course, is that you bleed intraventricularly, that clots, matures, and then you get hydrocephalus on top of it. So the expanding ventricles give you essentially a cast of the earlier size of the ventricle. So that is a big AVM with acute intraventricular hemorrhage. All right, this next one is, oh, I broke my rules. Sorry, I did include one contrast study. I knew it was in there. But you can't really show this one without contrast. So this one is a CTA, and this is moyamoya. This can arise due to a number of abnormalities, usually involving the skull base and usually causing occlusion of the carotids for that reason. And that's what we have here. You can see these tiny, wispy little vessels all coming together and ultimately reconstituting the standard five-pointed star of cerebral vasculature. But in order to get there, it's got to come up through a puff of smoke of all these tiny dilated collateral vessels. This patient, obviously, you have to gather up a huge head of steam to push that blood through all those numerous tiny narrow vessels. And so it's not surprising that this patient ultimately presented with a hypertensive bleed. And there that is. So let's look at the carotid though. Follow that carotid artery up and it kind of vanishes and you see nothing but tiny little wispy vessels all reconstituting the more normal cerebral vasculature. And there, of course, is that acute hemorrhage. Let's watch that one more time. Follow those carotids up the canal through the siphon, and then they just kind of vanish into a bunch of tiny, wispy little collaterals. And there again, the hemorrhage. So that is a case of moyamoya. Don't know if I mentioned this patient had underlying sickle cell anemia, which they believed had contributed. All right, a large hypodense mass here in the splenium of the corpus callosum, causing significant vasogenic edema. Nice example there. And there is an associated density, and this is important. Your differential on these corpus lesions that actually have mass effect, you're thinking, well, possibly lymphoma, not typically showing calcification or hemorrhage, though. And in fact, metastases, MS, the sorts of things you might be thinking of, that presence of density, either calcification or more likely some non-acute hemorrhage, is really suggestive of a GBM, which of course is characterized by necrosis and hemorrhage. So it's a helpful sign there, and that is in fact what this was, an acute presentation of. You see there's even some asymmetric hydrocephalus, vasogenic edema extending all the way up into the parietal lobe, and sulcal effacement throughout the entirety of the left hemisphere. We'll let that run one more time. All right, so that is a GBM with non-acute hemorrhage, but an acute presentation with vasogenic edema and obviously significant shift. All right, I think this is our last one. This is a pituitary macroadenoma with hemorrhage. These have a tendency to present with acute hemorrhage. So there it is. It's actually arising from the sellar region. And on the movie, you'll appreciate there is expansion of the sella. And this lesion goes superiorly from the sella, has a kind of bilobed appearance to it, and as you can see, is complicated with acute hemorrhage, both around the lesion itself, but also into the adjacent ventricles. So the macroadenoma has a real tendency, like the GBM, to necrose and ultimately hemorrhage. And this is the snowman appearance, where they tend to have a waist where they have crossed the diaphragma sella. So this one's kind of an upside down snowman because the superior portion is so large. But all the same, you can appreciate that phenomenon. We'll watch this one again and try and spot that posterior clinoid kind of levered backwards right here. Yeah. That sellar expansion really suggests that's where it all began. And there is the acute hemorrhage from the lesion and into the ventricles.